So just another acknowledgement. Do you all know who this is by a show of hands? So not everyone knows. This is Henrietta Lacks. And if you do not know her story, I'm not even gonna go into her entire story because I would love for you all to search her name. And if you want to do it right now while we transition to the other speaker, you can. But in everything that we do, we should always acknowledge Henrietta Lacks. In short, she was someone who had cervical cancer, whose cells were taken away from her in Baltimore, Maryland at Johns Hopkins Hospital, where I was treated, and they saved my life, and I love them. And it's a double-edged sword because I hate what happened to her and her family, but the truth is, without her and her family, we wouldn't have an HPV vaccine or a lot of vaccines in this country. And so one of the things that Dr. Leela Pender did that really pressed upon us, show of hands of who was at Survivor School in Seattle. And so, Dr. Pender, at the top of all of her presentations and events, she gives honor to Henrietta Lacks. And one of the things that we have decided to do as an organization and all the work we do is also give just honor to Henrietta Lacks, her life and her HeLa cells, and what was taken from her family, and also what we've gained despite the heartache that caused from her family, and not just having it done in February for Black History Month. It's something that as an organization we're committed to doing year round. And so I challenge you all to consider doing the same thing as you tell your stories, as you do this great work. And with that, we're ready for Dr. Oni. Okay, I'll hand it back over to Christy, but make sure, if you're not familiar, HeLa cells, Henrietta Lacks.
One quick note of housekeeping, restrooms behind that screen right over there. So if they are needed. Oh, I'm sorry. I was just saying the restrooms, if they are needed, are right over there behind the screen. It is our privilege to welcome to the Cancer Summit stage, Dr. Oni Balogun. As an assistant professor of radiation oncology at File Cornell, I'm so sorry, I don't know where that is, Cornell Medicine. Dr. Balogun is leading the charge in transforming cancer care and bridging global disparities. From her pioneering work as CMO co-founder of Mission Driven Tech to her groundbreaking research initiatives, she embodies a commitment to advancing health equity and revolutionizing treatment paradigms. Let's give a resounding applause for Dr. Oni Balogun.
Thank you all so much. I hope everyone can hear me. Thank you all so much for the honor of being invited to the Survivor
You are on
Summit.
mute.
Oh, pardon? Can you hear me? I just want to make sure you're able to hear.
Hold on just a moment. We are trying to repair it.
Great. Okay.
Dr. O, you want to try again?
Yes. Can you hear me now?
Hold on.
We on Zoom can hear you. The issue might be in the room.
Do you want to try again?
Can you hear me now, or should I go and come back in?
For me, I can hear the doctor talking. For me, I can hear you.
Great. So people on Zoom can hear me, but I don't know if the people in the room can hear me.
Yes.
So you can hear me now?
Yes, we can. Thank you.
No worries. So I just want to thank, especially Morgan, Tamika, and the entire Survivor Network for the invitation to speak today. I will be talking about what's the latest in cervical cancer, just initially providing an overview of a disease that unfortunately many of you know all too well, and then hopefully talking about some exciting things that might move us forward in our progress towards elimination of cervical cancer. So at this time, I will, can you enable me to please share my screen?
You should be good now.
Thank you.
Could you try it? We're testing some audio in the room.
Mm-hmm.
Do you see the share screen? Okay, great.
Right. So... All right, so regarding cervical cancer, unfortunately, we know that worldwide, there are continue to be growing inequities. So I was born in Nigeria, and I take a global perspective of this disease. And what we see is that this is a cancer that in the United States, we know that we have a lot of strategies like prevention through vaccination, screening through the HPV and PAP test, and of course, treatment. We have a lot of strategies to try and tackle this disease. Unfortunately, many other countries, especially low and middle income countries, don't have that access to all those tiers of prevention, screening, and treatment. So what we see here, and these are some slides from individuals at the WHO, showing that the incidence of cervical cancer is basically highest in parts of Asia, sub-Saharan Africa, and also parts of South America. We know worldwide we have about 600,000 cases, and unfortunately, close to 400,000 deaths. So we do have a ways to go. We are all too familiar with the strategies that have been announced to try and eliminate cervical cancer. I was really surprised when this week I learned that Australia, they are now on track to eliminate cervical cancer by 2029. And I used to always think it was 2035. That's what they initially started at. And to hear that it's now moved up 6 years, it just shows you that if there's a will, there's a way forward. So let's see how we can move that needle. When it comes to cervical cancer elimination, there have been a number of different strategies that have been put in place, and these are models showing us that we can drastically decrease the mortality of this disease, drop it by 34% by 2030, if we implement a number of different things like vaccinating, focusing on vaccinating girls, focusing on making sure that individuals have been screened at least twice in their lifetime, and focusing on getting cancer treatment in place. Clearly doing only one of those, like only focusing on girls, is only going to get us to the blue line in terms of suppressing mortality due to cervical cancer. But if we implement a number of those strategies, we stand to bring down mortality to by 99% by 2120. So that's what I and many other individuals in this room are hoping to see. but we have a ways to get there. So when it comes to HPV vaccination, there are a number of issues, right? Because one of the main things is that we are not getting the global coverage that we need. In particular, low and middle income countries are really quite far behind when it comes to vaccinating girls who are 15 or younger, or boys who are 15 and younger. We haven't, even come close to yet being at 20%. These data show that the vaccination programs have been introduced primarily in high-income countries. So we have to find ways, if we're going to have a global elimination strategy, for us to get the vaccine to more people, especially in low and middle income countries. And then when it comes to screening, lifetime ever having been screened, again, drastically varies according to which countries you have been in. So high-income countries have a high percentage of women having been screened. We know that about 63% of countries have had more than 70% of women being screened who are 30 to 49 years of age. We know that over 63% of countries have had that. But when it comes to getting higher than that, having more than 70% of women screened, which is what we're aiming for and we're targeting, just under 40% of countries have achieved that. And one thing I want to talk about is, what are the barriers to this? And so one of the barriers to this is that sometimes the screening process can be too complex. You have to find a caregiver, namely a gynecologist, and you have to get an appointment for them. And do you have the time, to invest in finding someone to give this screening test to you? The other question is, do you have the money? Do you have the knowledge in order to know that you need these tests done? So some of the things that were talked about, yesterday, and I think, I just want to take a moment to congratulate Tamika and my friend and business partner, Eve McDavid, on participating in the White House Cervical Cancer Forum yesterday. I hope many of you were able to tune in and hear their remarks. And at that White House Cervical Cancer Forum, they announced in the United States a bigger push for screening. In fact, they're talking about self-testing. So there have been a number of studies that have been done about self-testing. And the breakthrough is that we know that those tests give just as good results as if it was performed by a physician. So what they launched yesterday is something called SHIP. It's a program and it's a pilot where 25 hospitals, including my center, Weill Cornell Medicine, are going to be enrolling women where they will receive a kit for self-testing in the privacy of their home. And we know that has the potential to really be impactful because when we look on a global scale, right, there's some women who are in countries where most of the practitioners are men. And there are, issues of modesty and not wanting to expose yourself to someone of the opposite sex. So if we can get women to be able to test at home, we can hopefully, address those issues of convenience, of, maybe not wanting to be only with a male practitioner, and hopefully we'll be able to see these screening numbers go up. So it's a long path to move forward, but at least in the United States, that's one of the things that are new, that hopefully we have testing on the horizon. And there are private companies like Teal Health that are also rolling this out. So I'm hoping that in the next 5 years, we'll be able to say, hey, you don't have to come in and, undergo that very unpleasant speculum exam. You can do this in the comfort of your home and detect this disease early. And why is it important for us to detect the disease early? So I want to draw your attention to this figure right here in the center at the top. What we're showing is the progression of cervical cancer. We know that cervical cancer, is primarily due to the human papillomavirus. And the human papillomavirus is the most common sexually transmitted infection. And it has many different strains. So it has many different types, and they are categorized by number. So you may have heard of HPV 6 or 11. Those are the types that are more so associated with warts. But then there are other types. The ones you may have heard of are 16, 18, 31, 33. Those are the types that we're concerned about because if they're not cleared by your immune system, and our immune system usually does a very good job at clearing the HPV, if they're not cleared, what they'll do is over time, they're going to lead to changes. So this is the normal cervical tissue. And these red dots here are the HPV, right? The infectious virus particles. And if they are not cleared by your immune system, they're going to cause changes in the cells. If you have, less than a third of your cells, the thickness of your cells, of your cervical tissue involved, we categorize that as a CIN or a carcinoma or a cervical intraepithelial neoplasia. You may also heard it be called a carcinoma in situ. That means it's in place. It's not yet a full-blown cancer that has the ability to travel to other parts of your body. So if it's only a certain thickness, a minimal thickness of your cervical tissue, we call that a CIN1. If it has gotten to a more advanced point where it is, invading more than 2/3 of the cervical tissue, we call that a CIN2. And then CIN3 is, you're basically hovering at the point of tipping over to a cancer that has invaded and broken through the basement membrane, or now has the ability to invade into other parts of your body, other tissues. So we don't want to have people progress and come in when they're at the point where there's cancer. We want them to be able to be detected at CIN1, CIN2, or CIN3. And that's the beauty of screening, that we can catch this before you progress all the way to a full-blown cancer. And so why does this matter? It matters because the treatment that you get depends on what stage you're at, right? So I'm showing over here on the bottom right, actually, if you have early, before it's a true cancer, you can undergo treatments like cryotherapy, where we freeze the tissues of the cervix. And that should be sufficient in many cases to take care of those that CIN disease, like CIN1, CIN2. Unfortunately, if you have more serious disease, you may have to undergo something called a cold knife conization. That's on the bottom left that I'm showing you. That's where they have to take a piece of your cervix out. And that can lead to more serious issues, like in terms of fertility, in terms of being able to carry a baby to term. So we want you to come in before you need a cold knife cone. But I want to reassure people that if you do need a cold knife cone, a lot of times, there's something that they can put in stitches if you do end up carrying a child. Having these procedures is not going to, it's not something insurmountable. So, but we still want to catch you before we have to start, taking pieces of the cervix out. And then I want to point out that if you unfortunately come in when you have cancer, what ends up happening is that you have to undergo both chemotherapy and radiation therapy. And that is what I want to be put out of business. I tell people, and I mean it genuinely, my dream is to be Janet Jackson's backup dancer. And I don't have that much time because she'll soon retire. But my dream is to have cancer go away so that we can all pursue other things. And so what I'm pointing out in the middle are these tandem and ovoids, right? And what happens when you're diagnosed with a cervical cancer that cannot undergo surgery anymore, so cannot, simply undergo a hysterectomy where they take out your cervix and your uterus. You're now subjected to 5 weeks of chemotherapy and then 5 weeks of radiation externally, followed by internal radiation. And this device is what I have to use right now in order to treat people internally and give them radiation to cure their cancer. And I'm going to talk a little bit more about the fact that it is not ideal. This is just I wanted to break down and show you, before, if you have CIN, like I said, cryotherapy, is probably what we're going to try and treat you with, in addition to other less invasive procedures. But if you have something that's now a true cervical cancer, you're going to need surgical management. And then if you're not operable, that's where we're going to start having to look at, external beam radiation plus chemo plus brachytherapy. And I don't want you guys to be in these sorts of stages. Okay. So we clearly need some more innovation, right? Because if you look at the trends, prostate cancer and cervical cancer in the 1970s had similar survival, 70%. Over the years, because there've been more investments in prostate cancer, and again, Eve and several others at the forum spoke eloquently about this yesterday, because there's been a focus on prostate cancer, investment in it, they're now sitting at nearly 100% of prostate cancer patients can expect to be alive 5 years out, whereas we're still hovering in the 70s when it comes to cervical cancer. And like we mentioned, I've done research, and many others have too, showing that when a mother dies, her children are more likely to die, especially if they're under the age of 10. And it doesn't matter if you're in a high-income country or if you're in a low and middle-income country, the effect is still felt. And sorry, fellas, but it doesn't matter if the dad is alive. And that's just really striking. So we need to do more. And what Eve and I are trying to contribute is we're trying to work together to redesign these brachytherapy tools. So right now, the brachytherapy tool that I use, it causes a lot of pain, up to 25% of the people that I take care of. And unfortunately, the majority of them are Black women. They tend to leave because it's just a very painful, time-intensive treatment. They have to undergo this procedure at least 5 times over the course of 2 weeks. Now, this procedure has been likened to childbirth, and who will willingly show up for something that is similar to childbirth 5 times in the span of 2 weeks? So even I put our minds together, and we redesigned this brachytherapy machine device to what we are calling the Blossom. We've made improvements that decrease the risk of someone perforating or putting a hole in the uterus accidentally during this procedure. We've also made improvements to make it less painful, much less painful than what would be considered similar to childbirth. And we hope that by making it more humane, we can bring more women to stay and finish their treatments, because if you have advanced cervical cancer, it's difficult to cure women without that internal radiation, that brachytherapy. So the other thing I want to talk to you all about in the time that I have left are on the treatment side. What kind of new treatments are being offered for women? I think you may have heard about immunotherapy, and that is a treatment where you give a drug, usually through the veins. You give a drug that is supposed to rev up the immune system. And there have been some studies showing that, possibly adding immunotherapy to cervical cancer may be a good strategy. So I want you all, if you go into your if you go into your appointments to talk to your doctor about, am I a candidate for immunotherapy? Right now, it's really for people who have metastatic or advanced disease, but we're trying to see if we should bring it up, if we should offer it to women who have, earlier stage cervical cancer. So stay tuned for that. The other thing I want to talk about is just a variation on how we've been treating women. This is a trial that was designed by my colleague, Mary McCormick. She is at in London, and she's a phenomenal radiation oncologist. And what she said is there a way for me to change the treatment such that we get better outcomes? And I just want to give you an overview of this interlace trial. So basically, this interlace trial looked at women who hadn't had pelvic radiation before. This is their first time being diagnosed with cervical cancer. And what she did is, instead of saying, okay, what you're going to do once you're diagnosed is get the weekly chemotherapy and the radiation at the same time, she said, can we add chemotherapy prior to that in order to enhance the outcomes and in order to treat cancer better? So what would happen is that women for 6 weeks, once a week, they would get 2 drugs called carboplatin and paclitaxel. So they would get it for 6 weeks, and then they would start getting cisplatin, which is usually our standard, for 5 weeks, once a week, with the radiation to the pelvic area, and then they would get their brachytherapy as well. And so what they ended up showing is that, it was a multi-institutional trial, including people from the UK primarily, but also individuals from Mexico, Italy, India, and Brazil. And what they showed, in this group that primarily had stage 2B disease, as well as squamous cell cancer of the cervix, is that they saw improvements. They saw improvements in terms of the outcomes, in terms of overall survival, as well as progression-free survival, meaning that you're living without the cancer continuing to grow. And so some people said, you're giving more chemotherapy. How is that going to impact, how people do? Will people be able to tolerate it? And what I want to point out is that when they were giving that 6 weeks of chemotherapy initially, over 90% of people got 5 treatments, at least 5 treatments. So it seems like people can handle it. We don't want to cause a lot of toxicities. We don't want to cause a lot of side effects, but we are trying here to see how we can, reasonably intensify treatment so that people live longer. And what they also showed here is, for the individuals who then went on to get their chemo plus radiation, 85% of those who had already had chemo were able to get at least 4 treatments of the cisplatin, right? And then 90% of those who got cisplatin regularly got at least 4. So it seems that people can handle getting chemo initially for 6 weeks and then coming on to get the cisplatin. And they were able to also show that, radiation therapy, it's not like people left the radiation because they gotten more chemo. They were able to receive their radiation therapy, 97% of them. And so you have some side effects. I'm a strong believer in letting people know you're going to have side effects. Any doctor that tells you, oh, it's going to be a breeze, I don't trust that. There were clearly side effects, with a number of people having, as we expect, a decrease. Neutropenia is a decrease in your white blood cells. So as expected, you're going to have more of a decrease in your white blood cells with more chemotherapy. But the good thing is that they didn't notice significantly higher level of, more serious side effects than what we're already doing. And so this is what, is the big take home. They noticed that progression-free survival at 5 years out, if you got this initial chemotherapy plus radiation, 73% of people were still alive who'd gotten that, compared to 64% of people. And also when it comes to surviving, who's alive, 80% of those who've gotten chemotherapy before starting chemo radiation were alive, compared to 72% of those who had gotten chemo radiation alone. And then the most important thing is just comparing to other studies who have compared to other studies where they've looked at how are cervical cancer patients doing. Those other studies show overall survival in the 70s, whereas this is showing, you know, almost a 10% improvement in survival. We don't often see that in oncology. And so this made me sit up, and we're going to be trying to replicate this, especially in low and middle income settings. So I want you all, you know, if you have a friend who's going through treatment or about to go through treatment, to just, you know, bring this up and say, do you think this might be a strategy for me? Understandably, you know, people want to give it a little bit more time, see 10-year results. I think these are good results, and we should be implementing them. But I just want to give you more information so that you can ask about those strategies, ask about immunotherapy, ask about, should I be getting induction chemotherapy when you are now faced with the choice of treatment. So I hope that was helpful, and I thank you all for your time and for listening.
If
And
we
now I'm
can,
happy to take
Dr.
any
O, we'd like to
questions.
take some questions from the participants.
Hi, I'm Cindy Trice. I'm a stage 2B cervical cancer survivor. And in October, I'll be 20 years from my last treatment. So thank you. I have a question about the brachytherapy. So when I had it put in under general anesthesia. So I didn't experience the pain of having it put in. However, I experienced the pain of having them take it out. But I was in for 3 days. I did it once. And so I was in the hospital for 3 days, kind of quarantined away. The bed was such that I couldn't sit up, so I wouldn't impale myself.
Yeah.
And I'm just curious, was that an old recommendation? Why did that change? Because I didn't have to make the choice to go back, you know, 3 times or I can't remember, 5 times in 2 weeks or whatever you said. Like, so, because I understand that's a barrier. Some women do it once and then are like, forget it, never again. Why has that recommendation changed?
So Cindy, first of all, I'm so excited. I love hearing, you know, about long-term survivors. So congratulations. That's a big deal. So that's a phenomenal question. There are different ways for us to deliver radiation therapy. So initially, what we were doing is called low dose rate radiation. And what that meant is that we would place the device and there was a continuous delivery of radiation. They would put a radioactive isotope internally inside, and that would give radiation over the course of a couple of days. And you would just have to lie still and stay there, and that's what you do. Then there came an invention called the afterloader. Basically, it's a machine where the radioisotope sits inside, and we can now have that radioisotope be brought out, you know, whenever we need it. So some people wanted that option because those radioisotopes give like a higher dose of radiation over a shorter period of time. And there was a thought that, you know, maybe some women might not want to stay in the hospital, you know, immobilized, because that can bring certain complications, like when you're not moving, higher risk of, you know, blood clots, right? as well as some other, you know, bed sores, a number of other things. So people wanted a way to kind of give a burst of radiation dose and then say, okay, now I can give another burst. And so that's called high dose rate brachytherapy. So it sounds like what you received, if they just placed it and left it for a few days and then afterwards took it out, that sounds like low dose rate brachytherapy, which they do in some countries still, but a lot of people are now using high dose rate to give, you know, a burst of radiation usually over like 15-20 minutes. You get the radiation dose that day, and then sometimes they keep you overnight in the hospital with the device in, and then give you another burst of radiation the next morning. Then they take it out, give you a break of a week, and then have you come back and do 2 more. But that's the high dose rate radiation that people have moved towards, and it sounds like you got low dose rate. Hopefully that makes sense.
Hi, my name is Davina. I am stage 2 cervical cancer survivor. I am from all the way Guyana, from South America. So I have a question. So I've heard about the immunotherapy. So is it to replace the chemotherapy, or is it to revamp our immune system?
Great question. And greetings. I consider myself an honorary Guyanese. I take care of a lot of Guyanese women. In fact, I'm,
Thank
you know,
you.
still no problem. I'm still slated to go and see Rupununi and see, you know, Guyana and all of its beauty. So I'm excited to hear your voice. So when it comes to the immunotherapy, at present, what they're doing is they are combining it with the chemotherapy to kind of enhance the chemotherapy. I don't know if there are trials right now underway that say, okay, can we just do immunotherapy alone? I haven't seen those in cervical cancer. There are some other cancers where they have, you know, first said, okay, what happens if we add immunotherapy to the chemo? Okay, now what happens if we just give the immunotherapy alone? Right now for cervical cancer, it's really, we combine the immunotherapy and the chemotherapy, and we see better effects in some trials. So that's it's supposed to enhance the chemotherapy.
Thank you, doctor. My name is Lori. I am a 6-year cervical cancer survivor, 1B1. My question is, within the last year, I have a confirmed diagnosis of lumboplexopathy 2L 2 through 4. So I am officially disabled. My question is, with all the other effects, is it the luck of the draw? Because I know it's rare, but the longer people are continuing to survive because of the treatment modalities, the more doctors are going to start seeing this because plexopathy begins later. So was it just the luck of the draw? Because it is considered a devastating diagnosis.
Thank you for sharing. And I empathize with you that you had this side effect. It's not easy. And, you know, I think sometimes people are like, oh, you're alive, but, you know, the quality of life also matters. So I hope that you're finding some ways to ease that discomfort. When it comes to, let me first start talking about side effects of the radiation, which are, you know, not insignificant. So the most common side effects that I talk to people about during treatment is fatigue. They're going to notice skin changes, a darkening and or redness of the skin in the pelvic area. They may also notice that they need to urinate more often because the radiation, even though it's focused on the cervix and the uterus and the vaginal area, there's some dose of radiation due to the laws of physics. We can't avoid it. That's going to spill onto the bladder in front of the uterus and cervix, and the rectum in the back, and some of the intestines. So we notice that people may have, you know, irritation of the bladder, and they'll need to use the bathroom more frequently. You'll have a softening of your stools. So those are the most common side effects. Less often, the more serious side effects are long-term. People can sometimes develop fragile blood vessels in the rectum, in the bladder, that can lead to blood in the urine or through the backside. So when that happens, you know, we have a number of ways to address it. The other less common is that radiation can affect the bones, right? And we try to decrease the risk of that by outlining the bones. And fortunately, we now have technology that we can say, hey, I want to deliver the dose here, and I don't want the bones to get any more than this dose, because we've studied it and we know that at this dose, you can have a higher risk of fractures in your sacrum. So now getting to lumbar plexopathy, which is basically, right, damage to the nerves in the lumbosacral region, in the lower back. That is much less common. Nerves are one of the most radiation resistant, in general, right? Nerves are some of the most radiation resistant parts of our body. They can take really high doses. So, you know, it's unfortunate, but like you said, it was kind of the luck of the draw, because everyone is different. And it sounds like in your case, you know, the nerves were damaged as a result. So it's not a common side effect. And right now we don't focus as much on what dose is going to the nerves. And also it's kind of hard to see exactly where the nerves are running, because they also vary quite a bit in each person. So it's not something that we track. But yeah, it's definitely an uncommon side effect. And I hope, you know, I'm sure you've been in contact with neurologists. We have to do more research about, you know, what leads to things like that are rare in other people, and how can we best treat it. We need to do a much better job of finding solutions for the side effects. We're focused a lot on the cure, understandably, but we also have to do a lot more research in terms of like solutions for side effects. And I'd be remiss if I finish this without saying one of the most common side effects is, you know, vaginal stenosis, side effects, vaginal dryness. We can definitely impact people's, you know, sexual health. And so that's something that we don't talk enough about. And we have to also make sure we talk about it and put people in contact with the right resources once they finish treatment.
Thank you. My name is Anna, and I was first diagnosed with HPV-16 when I was pregnant with my first child in 2008, and then was diagnosed with stage 2 adenocarcinoma in 2015. And since then, I have also had precancerous lesions on my vaginal wall, and then last year developed stage 0 vaginal cancer, did chemo, and then had to have a partial vaginectomy. And I'm still HPV positive. It's never gone dormant in my system. And I'm just desperate to figure out how or what studies are being done for those of us that have remained HPV positive for me, it's 17 years. And so I know I'm at a high risk for all of the other HPV related cancers. And that it continues to be something that I'll have to deal with. But are there studies now being done on how to help people whose immune systems are just not fighting it off? I've gotten the vaccine. It didn't do anything. So I'm just wondering what else is out there. Is it immunotherapy, or what's being looked at for those of us in this situation?
No, thank you so much for sharing your journey with us. And I can hear the frustration and with good reason. So when it comes to, I don't know off the top of my head, But I will take a look into it, and I'm happy to pass that information along to Morgan or Tamika. Honestly, I think my guess would be that cervical cancer research in general is underfunded. And so, that's a very specific question about HPV persistence and what can we do for those individuals to help them clear the infection. I'll take a look out there to see what's out there. And I'm happy to forward that to Tamika and Morgan. But it is not something that is being widely studied. But I'll look to see. I hope there's something out there that we can connect you with. Clinical trials are key, in this sort of setting.
Dr. Oni, thank you so much for your time. We really appreciate it.
It's my pleasure. Thank you for having me.
Thank you. We are going to take a quick mini break while we set up the stage for our next panel. So feel free to use the restroom, shop the merch table, get a beverage.
It's just this one that we think
I sure will. Thank you. I thought it was in the line. I'm a multi-fluid kind of gal. You need multiple fluids to get through the day, like live at the same time. So I feel you. That's why I was like, keep coming. Of course.
My sister, business women's conferences and they just like more. This is amazing. I said we have lots of areas. Yes, no, there's nothing, there's no indication of what. Almost. So not like in the first. And then they. They have office, workspace, they have, forget all the different things, that not be doing. So. Doing good. Yeah. He was like relieved that he didn't have to drive.
If you'll begin to take your seats, we will start in a few minutes.
We talked about making it a date. We could make it a date. And they were like, what, let's make it a date. Like you all get together, schedule them together, and then maybe go out to a big celebratory lunch or something. Make it not so daunting and such a chore that, I mean, no one is doing it, but, you know, get some element in there that makes it something that you want. Yeah.